तिवारी जी
हाँ जी सर।
तिवारी जी स्टार्ट करें?
यस सर।
ठीक है। Okay, a very good morning to all of you. So today we'll discuss something about leprosy and its therapeutic options for its treatment. So leprosy, as you know, it is called as also Hansen's disease, and it is a chronic infectious disease caused by some Mycobacterium leprae organism, which is of the same species of Mycobacterium tuberculosis. As you know, tuberculosis is a wide prevalent disease and it is a disease of national concern. Similarly, if you consider leprosy, it is also a disease being confined nowadays towards the lower income countries or developing countries like India. And it is mainly a granulomatous disease affecting peripheral nerves and mucosa of the upper respiratory tract. Okay. So granuloma, it refers to the lesions of epithelial macrophages. Macrophages invades these lesions and they engulf the surrounding tissues and make it necrotic. Okay. So Gerald Henrik Amar Hansen, who has discovered first time this Mycobacterium leprae organism, that's why it is called as Hansen's disease. So if we'll see what are the common nerves, as you know that it involves the peripheral nerves. What are the nerves being commonly involved? These are the facial nerves, median nerves, and ulnar nerve, and radial nerve, common peroneal nerves, and posterior tibial nerves. Okay. And it not only affects these nerves, it leads to certain deformities also. That's why in our society, few years back, it is called as a stigmatic disease. Okay, stigmatic conditions. People avoid to touch these persons having this leprosy, and it causes certain deformities in their hand, in their feet, or in their face. Some discoloration, disfiguration occurs in the bodies. Okay. So it affects skin and marginal nerves. Nodules or macules that enlarge it initially can be skin lesions. Okay. Or maybe without skin lesions, having nerve involvements. So nodules and macules appears on the skin that enlarges and spreads with loss of sensation. If untreated, this damages the skin, nerves, limbs, eyes, and lead to paralysis, wasting of muscles, visual problems, and deformities in the bodies. So it can be classified into two types, postivascular and multivascular types. And you can see this classification based upon the characteristics. It can be based upon the skin lesions. There may be 1 to 5 lesions in postivascular, or in multivascular, there can be 6 and above skin lesions. Okay. And coming to peripheral nerves, there may be no nerve involvement or only one nerve involvement in postivascular. Here, there can be more than one nerve involvement. Skin smear test is done generally, and to see whether there is this Mycobacterium leprae organism is present, bacteria is present or not. And it is negative at all sites in the postivascular cases. However, it is positive if you will take any site, any lesions. Okay. Coming to diagnosis, this organism cannot be cultured. It is very difficult to culture these organisms. Like Mycobacterium tuberculosis, for LJ media is required. It is not culturable in normal simple medias, agar medias. Similarly, Mycobacterium leprae also cannot be cultured in LJ medium. So it is only cultured in some organisms, some animals, that is called as armadillo. Okay. So this is thought to be due to the fact that it is no longer has the genes needed for independent growth, this Mycobacterium leprae. So because of inability to grow on agar and nude mice, so nude mice, these organisms are used. Nude mice means they are devoid of pores. Okay. And 9-banded armadillos. This is a creature. This is called as armadillo, and this has 9 bands in the back. You can see this. These are the bands. These are used culturing of these Mycobacterium leprae organisms. Okay. These are the animal models available. So diagnosis of leprosy, it is at least one of the following cardinal signs. One is definitive loss of sensation and a pale or reddish skin patches, hypopigmented patches. Generally, in Indian context, the skin color is not so much fair, so it comes as a hypopigmented patches. Okay, so it can be thickened or enlarged peripheral nerve with loss of sensation and or weakness of the muscles supplied by that nerve, and presence of acid fast bacilli in a slit skin smear. Okay, you have to give a nick in the skin and take, by scraping, you can take a little bit of tissue and spread it in a glass slide, and then you can do this smear examinations, slides examinations. Okay. So coming to problem status, last Sunday of January of every year is considered as World Leprosy Day. Despite of this elimination of leprosy being carried out as a program, national program, it is called as National Leprosy Eradication Program, NLEP. Still, it is being seen in some cases, rare cases are being reported, and it is a reporting disease nowadays. If you are not reporting this case, then you will be punishable. Okay. So India had eliminated leprosy in 2005, but still there is a prevalence rate of less than 1 per 10,000 cases. Some cases are being reported sparingly in some places. Okay. So coming to pharmacotherapy, it is a disease of historical disease. That means it is being present from the long years ago. So there are so many drugs has been tried in this case, but currently the drug regimen is called as MDT, means you are not using a single drug, you have to use multiple drugs for its treatment, otherwise it will show resistance. Okay, so drug resistance is quite prevalent in leprosy cases also, just like in Mycobacterium tuberculosis you have MDR tuberculosis, HDR tuberculosis. Similarly, there are drug resistant cases are there in case of leprosy also. Sometimes even after the drug treatment, there can be some lepra reactions. Okay, means the antigen being released from these organisms after this treatment will lead to some antigen antibody like complex reactions, or there can be some hypersensitivity type of reactions that can lead to lepra reactions. So we'll consider what are the lepra reactions and how we'll manage this. Okay. So coming to historical treatment, Chaulmukra oil was used as an anti-epileptic agent. And 1949, Cochrane et al. A study has employed that parenteral dapsone can be used for this treatment. And since 1949, dapsone is used orally. And in 1981, WHO has introduced multi-drug therapy for leprosy, and since 1983, it has been employed in India. Okay. So these are the drugs available for leprosy treatment. You have sulfons, that is dapsone DDS. It is sulfon is called dapsone. It is a sulfonamide group of drugs. Then phenagen derivatives, clofazimine. It is a dye, just like a coloring dye. It is a dye. Okay, clofazimine dye. Anti-tubercular drugs can be used in this condition, like rifampin or rifampicins. Ethionamide can be used. Okay. Coming to other antimicrobials, these are called second-line antimicrobial drugs or second-line drugs for leprosy. You have ofloxacin, moxifloxacin, minocycline, clarithromycin. So these are used when there is resistance to multi-drug therapy consisting of mainly these above drugs, dapsone, clofazimine, and rifampicin. Okay. Whenever you have rifampicin resistance, then you can add two of these second line drugs. Okay, either ofloxacin plus moxifloxacin along with clofazimine. Clofazimine resistance is very rarely seen. It is not being seen because it is dye. So generally rifampicin or dapsone resistance is seen. So if there is rifampicin resistance, so then you can use two of the second line drugs, that is either ofloxacin, moxifloxacin, minocycline, or clarithromycin. Along with that, you have to use clofazimine. Okay. So let's come to individual drugs. So dapsone, it is, as I have told you, it is a sulfonamides. Okay. So amide group is there and sulfur is there. Okay. So it is called as sulfonamide drugs. It acts through inhibition of bacterial folate synthesis, just like all other microbial sulfonamide drugs, inhibits the folate metabolisms. It's a bacteriostatic drug. Okay. It's given orally and absorbed, well absorbed it is, and tissue distribution is quite good all over the body. It produces 10 times more concentration in the diseased skin than in the normal skin. Okay. So it has more preference to the skins. Okay. Plasma half-life is about 24 to 48 hours. Dose is 100 milligram once daily. Coming to side effects of ADRs, the main concern is anemia. Yes. The thing is that leprosy is commonly seen. It is how it is being spread. It is being spread by airborne disease. It is airborne disease. Okay. Just like mycobacterium tuberculosis, it is also airborne disease, though it is affecting the skin or nerves, but it is not a disease contaminated through touch. Okay. It's mainly a airborne disease. And it affects mainly the lower income populations or the populations having less hygiene conditions. And that's why it affects the poor people mainly. You can say poor or backward peoples. So the thing is that these poor and backward peoples are already having some anemic-like conditions because of nutritional deficiency, because of the hookworm infections. Okay, so anemia is already prevalent in these type of communities, and again, dapsone can precipitate this anemia. So most of the patients of leprosy are being supplemented with the iron supplementations and hookworm treatment for hookworm infections. Okay. Basically, it affects children, so children should be treated with hookworm infections if they are suspected with anemia during these leprosy treatments. So coming to other side effects, it can cause hemolysis of red blood cells, and if there is G6PD deficiency, then it can be more precipitated. So it is contraindicated in case of severe anemia and G6PD deficiency. It can also cause methemoglobinemia. It has some GI side effects like anorexia, nausea, and vomitings. And sometimes it can cause allergic or hypersensitivity type of reactions that can lead to fever and allergic exfoliative dermatitis. Exfoliations or skin out will be theirs. Okay. It can cause neuropathy, hepatitis, nephritis. If there is hepatitis, then you have to stop the dapsone for a few days and see whether it is the causative agent. Then accordingly, you have to switch over to other second line drugs. If it is causing nephritis, then also you have to stop the drugs. See its monitoring. It can cause lepra reactions and exacerbations of lepromatous lesions, and we'll come across the lepra reactions later on. Coming to clofazimine, the next drug, it is a dye. I have told you it is a dye. It interferes with the template function of the DNA. It is a leprostatic drug. It has anti-inflammatory activity and useful in patients in whom dapsone caused drug reactions. So the peculiar point is that its T-half is 70 days. Okay. Another drug having this type of T-half about 90 days is called amiodarone, that is used in arrhythmia. Okay. So you should remember these drugs having very long T-half, and you should remember the drugs having very short T-half, that is adenosine. Okay. So it is a drug having very long T-half, 70 days. So coming to its side effects, as it is a dye, So it can cause discoloration of the skins. Not only skin, it also discolors the urine, body fluids. Okay. So what is the remedy for this? You have to reassure the patient that it will fade after completion of the treatment. It is a temporary thing. Okay. Ichthyosis. Coming to ichthyosis, it can cause dryness and scaling of the skins and itchings. And remedies are apply oil to the skin to have a smoothing actions and to reassure the patients. Coming to eye, it can cause dryness and moistening of the eye by using hypermethyl cellulose eye drops is required. Sometimes it can cause abdominal symptoms, abdominal pain, nausea, and vomiting. And it can be mainly seen in case of type 2 reactions if it is used in high doses, and symptomatic treatment is needed for this case. Okay. Coming to rifampicin, it is anti-tubercular drug, also effective in leprosy. It is a bactericidal drug. The previous two are bacterostatics, leprostatic drugs, dapsone and clofazimine. But rifampicin is the cidal drugs. 99.99% are killed in 3 to 7 days. They release the nasal symptoms in 2 to 3 weeks. Nasal symptom means, yes, as I've told you, it is an airborne disease, so it can cause nasal stuffiness and nasal blockage also. So it can skin lesions can start regression in 2 to 3 months. It is used in MDT. It is not used as a single drug in case of leprosy treatment. Okay. For leprosy, for tuberculosis, for malaria, for this type of disease conditions should be treated with multiple drugs, not only single drug because of concern of drug resistance. Okay. So it is used as the MDT at a dose of 600 milligram once a month. In tuberculosis, it's used daily basis, but here it has to be used once a month. Okay. Coming to ADRs, is it can cause urine and body secretions to be orange red colors. It can cause cutaneous syndromes like flushing, pruritus, rash, watering in eyes. It can cause flu-like syndromes, and it can be fever, headache, malaise, abdominal syndromes. It can have respiratory symptoms. It can cause breathlessness, shock, and sometimes it can lead to collapse-like conditions due to hypersensitivity reactions. It is contraindicated in case of hepatic and renal dysfunctions because it can precipitate hepatitis. Okay, and sometimes it can lead to lepra reactions, that is erythema nodosum leprosum. It is a type 2 lepra reactions, and there can be reversal reactions. Coming to ethionamide, it is a ethyl isothionicotinamides and chemically related to isoniazides. Act synergistically with dapsone, and the dose is 250 milligram per day. Other drugs, you have fluoroquinolones like ofloxacin, moxifloxacin, sparfloxacin are effective. These are bactericidal, but not norfloxacin or ciprofloxacin. Okay. Not all the fluoroquinolones are effective. You have some specific fluoroquinolones, these are effective in leprosy conditions. Okay. And this is bactericidal. So 400 milligram per day of ofloxacin can kill 99.9% bacilli, and 22 daily doses has been shown to be effective in case of leprosy treatment. And the efficacy is somewhat less than the rifampicins. Rifampicin has 99.99% bactericidal properties. So it is used as an alternate drugs. Moxifloxacin is the most potent drug among these fluoroquinolones. Okay. Similarly, moxifloxacin is the fluoroquinolone most potent in tuberculosis also. Moxi and ofloxacin are used in case of tuberculosis. Okay. Minocyclines, these are lipid-soluble tetracyclines, penetrate the Mycobacterium leprae. Tetracycline have three conjugate drugs: tetracycline, doxycycline, and minocyclines. Okay. Doxycycline, as you know, it is a drug having less toxicity than the tetracycline group of tetracycline drugs. And minocycline is another conjugate. It has also less side effect as compared to tetracyclines. It has protein synthesis inhibition mechanism actions, just like tetracyclines. And a dose of 100 milligram per day produces plasma levels that exceed minimum inhibitory concentration of mycobacterium leprae up to 10 to 20 times. Okay. So coming to adverse effects, vertigo is the main side effects of these drugs. It can cause photosensitivity or photosensitization of the skins also. Okay. Coming to clarithromycin, it is orthomethyl derivative of erythromycins, macrolide group of drugs, and 500 milligram daily doses kills 99.9% bacillus in 8 weeks. Okay. Coming to metabolism, it is metabolized inside the liver and excreted through the urine, and dose adjustment is rare in case of kidney disease. So we have seen the different drugs that are effective in case of mycobacterium leprae. Okay. And there is drug resistance to this group of organisms quite prevalent in our society nowadays, in India. Okay. So we'll see what are the genes which are responsible for the resistance to certain particular group of drugs. Rifampicin, the rifampicin resistance is because of this gene, RPOB gene. This is a DNA-dependent RNA polymerase of beta subunits. If it is mutated in the mycobacterium leprae, then the organism will be resistant to rifampicin group of drugs. Okay. Similarly, dapsone, folate polymerase. So dihydropteroid synthesis function is impaired. Similarly, ofloxacin, it is a, as you know, it is a DNA gyrase inhibitors. So if GORA gene is altered or mutated, then this DNA gyrase function will not be inhibited in case of mycobacterium leprae by these fluoroquinolones. So at least you should remember the name of the genes which are responsible for resistance in case of these bacteria. It is not only for this bacteria, it is also for mycobacterium tuberculosis also. Okay. Coming to MDT of leprosy, is irregular and inadequate duration of treatment with single drug have allowed emergence of resistance. Okay. That's why WHO has introduced MDT in full-fledged in 1984, though it has started from 1981. And in India, it has been implemented since 1983-84. Okay. And in recently, WHO has revised its MDT regimens in 2018. Okay. We will see the revised regimen and what is the previous regimen also. So goals of MDT is to prevent the emergence of dapsone resistance, to render multivectorial leprosy, multivascular leprosy cases to be non-contagious, to reduce the duration of therapy, to eliminate the dormant forms. Yes, it is a concern. Leprosy maintained as a dormant form in the subject, and it can lead to a re-emergence or relapse conditions after many years of treatments also. So dormant form are to be killed also. Multi-drug therapy is effective in killing the dormant forms. Okay. So coming to the current 2018 WHO recommended regimens, adult, this is the age groups, this is the drugs to be given, and this is the dosage frequency. This is the duration of treatment for multivascular and post-vascular leprosy. Okay. You can see for multivascular and post-vascular, both the types of leprosy, the WHO has recently recommended that all the three drugs are to be employed. That is rifampicin, clofazimine, and dapsone. Okay. And the duration of treatment will be different. In multivascular, you need more or longer treatment, that is for 12 months. In post-vascular, it is to be for 6 months. But the drugs regimen are to be same. Okay. But previously, there are two drugs being employed for post-vascular leprosy. That is, rifampicin and dapsone are employed for post-vascular, and rifampicin, clofazimine, and dapsone are employed for multivascular leprosy. But nowadays, WHO has changed its regimens. Though the changed regimen has not been implemented in India's NLEP, National Leprosy Eradication Program, in NLEP still we are using the previous regimens. Okay, 2 drug in possibacillary, 3 drug in multivascular leprosy. But it will be better to shift to WHO recent regimens. That is, all the 3 drugs are to be employed in all the cases, types of leprosy. So coming to rifampicin, its dose is 600 milligram once a month. Yes, it is to be given once a month dose basis. Clofazimine, 300 milligram once a month and 50 milligram daily basis. And dapsone, it is to be given 100 milligram daily basis. So all these drugs are orally given. Okay, and the thing is that you have to give the first dose. It is comes as a blister packet, MDT blister packet. Okay, so you have to administer the first regimen, first dose on a supervision basis. Okay, under your supervision, the patient has to take the drug. Okay, so 600 milligram once a month and 300 milligram once a month, these doses are to be given, and 100 milligram daily dapsone are to be given on a supervision basis. Then after, you have to give the packets, hand over the packets to the subject and ask him to come back with the empty packets to you, so that you can assess the compliance, whether he has taken the medicines or not. Okay. So in case of children, you have to give some lower doses, that is 10 to 14 years, you have to give 450 milligram once a month, rifampicin, and clofazimine similarly, half the dose, 150 milligram once a month, and 50 milligram daily, and dapsone 50 milligram daily. And in case of less than 10 years or weighing less than 40 kg children, then accordingly you can give rifampicin 10 milligram per kg once a month, and clofazimine 6 milligram per kg once a month and 1 milligram per kg daily, and dapsone 2 milligram per kg daily. The thing is that duration will be same. For multivascular, it will be 12 months, and possibacillary, it will be 6 months. Okay. The thing is that clofazimine is available at the lowest strength. The tablet's lowest strength, a capsule lowest strength is available as 50 milligram. So even if the children is less than for 10 years, we cannot divide the dose as 1 milligram. If the children is of 10 years, 10 kg, then it needs around 10 milligram per day. But it is not available to give a capsule of 10 milligram per day. So that's why the 50 milligram weekly dose is to be given. If the children is less than 10 years and its dose is coming less than 50 milligram per day, then you have to give 50 milligram weekly dose. Okay, instead of daily dosing. So coming to current regimens in NLEP, National Leprosy Eradication Programs. So as I have told you, we are still practicing the 2 drug and 3 drug regimens. So multivascular leprosy, we have to give rifampicin the same, dose is same. Okay, but only 2 drug and 3 drugs regimen is different. So it is to be given in adult. You can consider rifampicin is to be given 600 milligram once a month. Dapsone is to be given 100 milligram daily. Okay, and the frequency is written here. Okay, then clofazimine is to be given 300 milligram once monthly, followed by 50 milligram once daily. Okay, it is to be given 12 months. And possibacillary, rifampicin is to be given 600 milligram once monthly for 6 months, and dapsone daily 100 milligram. Okay, and coming to recommended regimens for drug-resistant epilepsy, if there is rifampicin resistance, then I have told you, you can go over 2 second-line drugs plus clofazimine. Okay, you can see here, ofloxacin plus minocycline plus clofazimine. It is to be given for 6 months. After that, for next 18 months, means here the treatment is to be for 2 years. Instead of 1 year, here is the treatment should be for 2 years. Okay, 18 plus 6 equal to 24 months. And here in the maintenance phase, you have to give ofloxacin or minocycline, means 1 second-line drug plus clofazimine. So initially 2 second-line drugs plus clofazimine, then 1 second-line drug plus clofazimine is to be given. Okay. So if there is rifampicin and ofloxacin resistance, then you can switch over to clarithromycin and plus minocycline plus clofazimine, and clarithromycin or minocycline plus clofazimine. Okay. Sometimes you can replace ofloxacin with levofloxacin or moxifloxacin also. So coming to alternative regimens, these are being seen in trials, but it has not been implicated or implemented in the drug treatment regimens according to the national programs. So alternative regimens are indicated in case of dapsone resistance. If they are employed only in cases of dapsone resistance or NDT regimen is not advisable. In these cases, you can give these alternative regimens, and these include intermittent RON therapy, rifampicin, ofloxacin, minocycline therapy, or 4-drug regimen, that is rifampicin, minocycline plus parfloxacin plus clarithromycin, or intermittent RMM therapies. Okay. So these are not having good efficacy as that of MDT. So let's not discuss about this. So have some idea about this. ROM, it is rifampicin, ofloxacin, and minocycline. I have told you it is to be given once in a month up to 6 months. Followed in postvacular, it is to be given for 24 months. And RMM, it is moxifloxacin plus minocycline plus rifampicin. Once a month up to 6 months in postvacular, and up to 12 months in case of multivascular. 4-drug regimen is only for multivascular treatments. Okay. So coming to slit skin smear and MDT. Okay. The slit skin smear is not a prerequisite for starting the MDT. Okay. MDT can be started on a clinical basis also, based upon the number of skin lesions, number of nerve involvement. It can be started. Okay. It is not, slit skin smear is not a prerequisite for starting the multi-drug therapy regimens. If in doubt, then you can do this slit skin smear, and along with that you can treat for multivascular regimens. Ideally, all patients should have one slit skin examination at the start of treatment to prevent missing cases of multivascular. Why it is required? If you are doubt that whether it is a multivascular or postvascular leprosy, then you can go for slit skin smear examinations, so that you will not miss the case of multivascular, okay, or not misdiagnose the cases. This is to prevent and multivascular case being treated as a postvascular. Skin smears are not needed to stop treatment or follow up after completion of treatment. No. You should not do a slit skin smear and found the negative test and you will say that I will stop the treatment. No. MDT is to be covered up till the duration of the treatment, because there are presence of dormant forms also. Okay. It is performed from the most active sites where clinical deterioration or relapse is suspected. Active skin sites, active skin lesions. Okay. All skin piercing procedures have potential risk of transmitting HIV and hepatitis infections. So that's why it is to be implemented. The slit skin smear examination are to be implemented only in these indicated cases. Coming to modification of duration of MDT, generally MDT is for 6 months and 12 months for postvascular and multivascular, but there are some alternatives are there. So postvascular leprosy 6 months regimens with interruption, then no need to restart. Complete the 6 months treatment. If in between the 6 months the postvascular leprosy cases have interrupted their treatment, then there is no need to restart the treatment of 6 months again. You have to, suppose after 2 months he has interrupted for 10 days or 5 days, then just complete the 6 months treatment. You have no need to restart the treatment. Multivascular treatment is extended to 24 months if the skin smear at 12 months shows no improvement in the morphology index. After 12 months also, if there is no improvement in morphology index by the slit skin smear examinations, then you have to extend the treatment up to 24 months, another course of therapy. Okay. Multivaccinal treatment restarted for another 12 months if more than 3 months delay in the past 6 months of treatment. Yes. In multivaccinary, if you are delaying it for more than 3 months or you have interrupted for more than 3 months, then you have to give another 12 months therapy. Then defaulter, that means they have not collected treatment for 12 consecutive months. They are given a new course of MDT. They are defaulter who have not collected their treatment. Patient has to come and collect the treatment, the blister packs. If they have not collected for 12 consecutive months, then they have to give in a new course of MDT. Relapse. Yes, in multivaccinal leprosy, there can be relapse conditions. And if marked increase at least 2 plus in the slit skin smear examinations over the previous value of mycobacterium leprae at single site, okay, then in case of relapse conditions, you have to again start a MDT treatment for multivaccinary. It may be a possivaccinary or multivaccinary in the previous conditions, but if there is relapse, then you have to switch over to the multivaccinary treatment. Okay, for 12 months treatments. Okay. So additional treatment with MDT, yes, it is not only that MDT treatment is required. Along with that, you have to take care of these conditions. Already damaged nerves will not recover fully, so you have to give additional treatments for these cases. Protect the damaged nerve supplied area and limbs. Correct footwear for the feet is to be administered. Treat any wounds or ulcers yearly. Okay, because there is nerve damage, so ulcers healing will be delayed, or there will be potential reinfections. So treat any wounds or ulcers properly and yearly. Careful when touching hot objects. You may not feel the temperature sensations because of loss of sensations. So be careful while touching any hot objects. You may burn your hand, but you cannot feel it. That's why you have to avoid the burn injury. You have to be careful. Okay. If blinking is reduced in the eye, there can lead to dryness of the eye. So you have to use artificial tears and glass. Okay, specs to be used. Physiotherapy and surgical treatment is needed if there is nerve damage. Okay. Coming to prevention of leprosy, yes, there are some options available for preventive prophylaxis also, chemoprophylaxis. If a person is coming in close contact with these cases, leprosy cases, so there can be some chemoprophylaxis to be administered. What is this? Single dose of rifampicin as a preventive treatment for contacts of leprosy patients, adults and children 2 years of age and above, after excluding leprosy and TB disease in the absence of other contraindications. Okay, if the subject is in close contact and he is more than 2 years of age and he is found to be negative for leprosy and TB, then you can give single dose of rifampicin. If the patient you have is in close contact but you have not tested him for TB and leprosy, then it is not good to give single dose rifampicin because it will cause resistance if the patient is already having this type of infections. Okay. So first of all, test these patients for leprosy and TB also. Test interventions shall be implemented by the programs that can ensure adequate management of contacts and consent of the index case to disclose his or disease. Okay. So coming to leprosy vaccines, is BCG vaccination has shown some effectiveness against this leprosy also, and the pooled reduction in risk is about 57 to 80% according to some studies. But still, you cannot say that BCG is a anti-leprotic vaccines. No. But it has shown some efficacy against the leprosy. So coming to lepra reactions, yes, you can see this is the examples of type 1 lepra reactions. There are two types of lepra reactions, type 1 and type 2. Okay. Type 1, you can have the skin patches which are being enlarged as compared to the previous patches in leprosy. Means after treatment, these patches will enlarge. Instead of shrinking down, they will enlarge. This is not because that leprosy is aggravated. It is because that there will be some lepra reactions. Okay. Like this, skin patches will be aggravated. Type 2, you will have erythema nodosum leprosum type of reactions, or macular papular regions will be there. Okay. Sometimes ulcerations can be there. Okay. So come to this type of reactions. So type 1, it is called reversal reactions. Type 2, sometimes it can precipitate into erythema nodosum leprosum or ulceration types also. So it is a delayed type hypersensitivity, type 1. As you know, that there are 4 types of hypersensitivity reactions. Type 1, 2, 3, 4. Type 1 is your IgE mediated. Type 2 is your antibody dependent. Type 3 is antigen-antibody complex type of reactions. Okay, arthros type of reactions. Type 4 is your T-cell dependent reactions, or delayed hypersensitivity, T-cell mediated hypersensitivity reactions. So type 1 reaction, type 1 lepra reaction is basically due to delayed hypersensitivity, and type 2 is due to antigen-antibody reactions. This mainly occurs in multibacillary cases, type 2. Why? Because there will be higher load of bacteria, and as the bacteria will be died off because of the treatment, they will release several antigens. This antigen will complex with the antibodies, and it will form arthros reactions or complex antigen antibody complex. They will get deposited in the microcapillaries, and they will lead to this arthros type of reactions. Okay, type 2 reactions. And type 1 reactions, it occurs both in possibacillary and multibacillary type of leprosy. And that is, and skin lesions, don't use these terms borderline lepromatous. All these are not used nowadays. Only these 2 terms are used, possibacillary and multibacillary nowadays. Okay. Skin lesions in type 1 reactions suddenly become reddish, swollen, warm, painful, and tender. New lesions may also appear. Okay. And here in type 2, you have red, painful, tender, subcutaneous nodules, and erythema nodosum lepromatous reactions can appear commonly on the face, arms, legs, and bilaterally symmetrical regions. They appear in groups and subside within few days, even without treatment. Sometimes they can subside without treatment also. So there can be mild, moderate, and severe type of reactions. So we'll discuss later on about its treatment. Then I will show you these things. So sometimes it can subside without any treatment also. So nodules are better felt than seen, and these are recurrent types, episodic types. Coming to type 1 reactions in nerve environments, nerves close to the skin may be enlarged, tender, and painful. Neuritis can be there, okay, with loss of nerve functions, and may appear suddenly or rapidly. That's why type 1 reactions, corticosteroid are to be given immediately. Okay. Coming to type 2 reactions, nerves may be affected but not as common as severe as in type 1. So nerve involvement is more common in case of type 1 reactions. And there can be dysfunctions also. That's why immediate steroid treatment is indicated in case of type 1 reactions. Okay. Other organs are generally not affected in case of type 1 reactions, and general symptoms are not common in case of type 1 reactions. However, in type 2 reactions, other organs like your eyes, testes, kidneys, they may be affected. This is because this is a antigen-antibody complex is being circulated in all over the body. Here, at the particular site, there will be more hypersensitivity type, or T cell will be more activated at these sites. That's why it is affecting the particular sites, nerve and skins. Okay. Here, all organs may have some effect, may be affected. So it can lead to fever, joint pain, and red eyes and watering of eyes. Okay. So comes to lepra reaction. If a patient develops lepra reaction during treatment, then do not stop the MDT. Complete the course of MDT. Lepra reactions which occur after the completion of treatment, then should also be managed with the steroids as per the schedule, but MDT should not be started again. This thing you have to remember. During the course of MDT, then continue the MDT, and if after the course of therapy, then do not reinduce the MDT again. Okay. So type 1 reaction, it is a reversal reactions due to type 4 hypersensitivity reactions. It is a cutaneous ulceration and multiple nerve involvement. Treatments are corticosteroids, clofazimine, analgesics, and rest. Okay. So you can give corticosteroids. Clofazimine sometimes can be used, and it has anti-inflammatory properties also, and analgesic and rest. But the thing is that clofazimine needs to be used in high dose as compared to the MDT regimen. So let's see. So type 1 reactions, corticosteroid are the drug of choice. You can give rest and analgesics. The schedule is for every 2 weeks, you have to reduce the dose. Initially, you have to give a high dose, 40 milligram prednisolone for first 2 weeks, then gradually reduce the dose every 2 weeks. Okay. In case of neuritis, then treatment is to be prolonged. Means if there is neuritis or it is not resolving, then instead of this 2 weeks every time, you can give it for 4 weeks regimens. So 4 weeks period can be started from 20 milligram onwards. Okay. From 20 milligram onwards, each period of 4 weeks treatment is to be given. Review every 2 weeks. If no response, continue further 2 weeks. Okay. So coming to type 2 reactions, it is erythema nodosum leprosum or type 2 reactions. So it is a type 3 hypersensitivity, humoral antibody response, antigen antibody complex reactions occurs. Existing lesions enlarge, become red, inflamed, and painful. Treatment is clofazimines, 200 milligram OD or 300 milligram OD also given once daily. Okay. Here, clofazimine in MDT is given 300 milligram once monthly, then followed by 50 milligram once daily. Here you can give 200 to 300 milligram once daily. I'll comment later on. Corticosteroids are to be given also, and thalidomide is the alternative to steroids. Along with that, you can give rest and analgesic treatment. Come to this, I have told you it is mild, moderate, severe types. So if it is mild type of reactions, few nodules and mild fever is there, you can give only analgesics. If severe pain over the nodules, tendency for ulcerations, high fever, or involvement of internal organs, then you can give steroids, and just like your type 1 reactions, but with a faster tapering. Okay. Means tapering should be faster. If there is neuritis, then prednisolone regimen as that of type 1 reaction is to be given. Coming to clofazimines, see, clofazimine is a slow-acting drugs. It needs at least 4 to 6 weeks for its onset. Okay. That's why you can give steroids initially, followed by clofazimine. You should not start with clofazimine in case of type 2 reactions, high dose. Okay. So it can help in steroids withdrawals. How to give it? It is to be given 300 milligram daily dose, but it can be divided 100 milligram 3 times daily because it can cause nausea, vomiting, and gastrointestinal side effects. So it can give in divided doses. Maximum it can be given for 1 month. This high dose. Okay. This high dose can be given maximum for 1 month, followed by its tapering, that is 100 milligram daily. This can be continued for maximum 1 year. Okay. If before that the patient is relieving, then you can stop this. Okay. So there is some difference between lepra reaction and relapse. How to differentiate this? Yes. Relapse means the disease is reoccurring. Lepra reaction is the treatment side effects. Okay. So time since completion of treatment, relapse usually more than 3 years. Usually more after 3 years, this relapse can occur. Okay. Lepra reaction usually occurs less than 3 years of MDT regimens, or even during MDT also. Okay. Progression of signs symptoms is very slow in case of relapse, but it is fast in case of lepra reactions. Site of skin lesions is few places in case of relapse, and it is lepra reaction, it is over the old patches. Pain, tenderness, and swellings may not be seen. Here it can be seen in lepra reactions. Okay. Damage occurs slowly in case of relapse. Lepra reaction, it can be sudden onset of damage. Nerve damage, paralysis, deformities, all these things. General conditions are not affected in case of relapse. Here it can be affected in case, like in type 2 reactions, it can affect any part of body organs. So treatment is MDT for multivascular leprosy, irrespective of the previous case. Irrespective whether there is paucivascular previously or multivascular previously, if there is relapse, then you have to go for multi-drug treatment, multi-drug therapy for multivascular leprosy. That is for 12 months treatments. And lepra reaction, the treatment as in lepra reaction we have discussed. Okay. So coming to conclusion, drug therapy for leprosy started with the salmopravir. Currently, MDT is being advised. Alternative treatment regimens are there, and drug of choice for lepra reaction is corticosteroids. Okay. So this is about your leprosy and its treatment. So thank you. If any doubt, you can contact me. Okay.